So she is going to have a new perspective as per CNS 5 classification. She's a pathologist, so she'll like to tell about the new guidelines about CNS classification.
So good morning, everyone. To my surprise, I find myself being the inaugural batsman, so to say, for today. So the topic allotted to me was the neuropathologist perspective in the AYA group as per the CNS5 classification, indulge or inner explorer. Now, as we have seen in the CNS5 classification, there has been a considerable change with the division of tumors into the pediatric type and the adult type, and there is no such thing as an AYA type of tumor. So it was a little scary for me that, oh my God, what perspective should I give for the AYA? But as you'll be hearing from Dr. Jalali, that these AYA group of tumors require a certain consideration for management because of the particular age. Similarly, I will try to convey to you the perspective from the neuropathology diagnosis point of view when we have a tumor of this age group. There are a lot of different definitions for AY age group, but I'll be taking the conventional definition of 15 to 39 years that is used in most of the studies. And these AY group need a certain kind of careful handling and management because of being at a tender age for a lot of other reasons besides the tumor and its management. And I'm sure Dr. Jalali will be speaking very eloquently on that in a little while. So I will not be talking about this. From the diagnosis point of view, the CB data shows that we have a certain set of tumors that can occur more frequently in children, more frequently in adults. And in the AY group, we have kind of a transition from this side to the other side and a kind of transition phase where the tumors kind of change their profile from the childhood type to the adult type. And even within the AYA group, as per the different age categories, a lot of different frequencies and locations have been described for these variety of tumors. However, from the neuropathology point of view, when I have a case in front of me for diagnosis, especially now as per the CNS5 classification, it may as well be for me AEUTS. Now the ways of acronyms. So what does AEUTS stand for? Anything and everything under the sun. So you really do have to put on your explorer hat, so to say, and pack your bags with things on according to the different terrain you'll be traveling on, and pick up clues along the way to reach your destination. So I'll be showing the approach to the AYA group of tumors, and no fancy cases, no very rare diagnosis, no long-worded diagnosis. Basically, I'll be showing a case-based approach to the routine histopathology practice. Completely cases picked up from the routine diagnostic reporting and with a limited setup or limited number of markers, how you can achieve the diagnosis. So I begin the series of cases with the first series, which I call a tale of 3 AYA. So it is, you can see there are 3 patients. One is 22-year-old male, 19 male, and a 17 female. All presented with different symptoms of ranging from seizures to headache to hemiparesis, 1.5, 6 months, 15 days. And on radiology, in the first and the third case, the tumor was kind of space-occupying lesions, hemispheric in the first with some heterogeneous signal and mild enhancement. And in the third, it was more of a midline lesion with heterogeneous signals and moderate enhancement. And in the second case, there was more of a diffuse infiltrating lesion involving multiple lobes, and the perfusion was high, suggestive of, again, in all 3 cases, the diagnosis was on radiology suggestive of a high-grade glioma. Now, this is the morphology of the first case. Diffusely infiltrating, kind of undifferentiated blue cells with some amount of pleomorphism, lot of mitosis, some areas of necrosis, and in doing a routine first initial panel of markers, it was IDH negative, ATRX was lost, PIV3 positive, and S3K-ME3 was retained, OLIG2 positive. Now, case 2, another very similar morphology, diffusely infiltrating, undifferentiated round blue cells, again pleomorphism, mitosis, no MVP or necrosis in this one. It was also IDH negative, ATRX lost, S3K-ME3 retained, and there was OLIG2 negativity in this case. Case 3, once again, undifferentiated round blue cells, diffusely infiltrating, pleomorphism, microvascular proliferation, and necrosis, mitosis. And once again, IDH negative, ATRX loss, P3 positive. OLIC2 was positive in this, and there was H3K-ME3 loss on the routine panel. So now we have 3 cases, all showing high-grade glioma, similar age group, high-grade glioma on radiology, on morphology, undifferentiated round cells, basically all high-grade astrocytomas, all showing IDH negative on IHC, and all showing ATRX loss. Now, on the next panel, you have some certain differences. P3 was positive in the first and the third, OLIC2 negative in the second, and H3K-ME3 loss in the third. So, as Dr. Jalali said yesterday, we should always never forget IDH as the first line of further investigation. And within IDH negative ATRX loss in this age group, that was the first molecular panel that we ran for case 1. And right off the bat, it was IDH R132S, a variant IDH1 mutation. And this was an integrated straightforward diagnosis of an astrocytoma IDH mutant, CNS WHO grade 4. Now, in case 2, IDH was for both IDH1 and IDH2, the sequencing was wild type. So, any guesses here from any non-pathologist in the group? Anybody would like to say what test next? It was a diffusely infiltrating gliomatosis like picture with OLIC2 negativity. Sir? So we ran histone. And as Sir rightly said, so Dr. Vani's talk has made a neuropathologist out of every year. So it is histone mutant G34R mutation was there, and it was integrated diagnosis of diffuse hemispheric glioma S3G34R mutant. Now in case 3, we have a midline location and we have H3K-ME3 loss. So again, yes, that is what we thought, but it was not so. S3K27 wild type as well as G34 wild type. So it was an IDH wild type, histone wild type. Now, are we dealing with an adult type of IDH wild type glioma here, or are we dealing with a pediatric type of IDH wild type, histone wild type glioma here? So, meanwhile, we got some additional history. The patient's elder sister was diagnosed as a brain PNET with multiple colonic polyps. There was no history of consanguinity, no FALA spots, but with this history, we went ahead with the next panel of markers, which was for the IHC4 MMR proteins. And yes, PMS2 and MLH1 showed complete negativity in the tumor as well as native cells, while MSH2 and MSH6 was retained. So this was a CMMRD associated glioblastoma. So now we have here the tale of 3 AYA with 3 diagnoses in the similar age group, similar on radiological diagnosis, and on the morphology very identical, all IDH wild type, ATRX loss. One turned out to be an adult type of diffuse glioma, astrocytoma grade 4, with a good median overall survival. The other turned out to be pediatric diffuse high-grade glioma with a poorer prognosis, and the third turned out to be a high-grade glioma with, which is technically falls under the pediatric type of diffuse high-grade glioma, though it is a genetic associated tumor. And here the significance being that the prognosis is poor, but there are a lot of ancillary other management issues such as genetic counseling, resistance to temozolomide, sensitivity to immune checkpoint blockade, and other surveillance for the tumors. So highlighting the importance of diagnosis with similar morphology and how we can approach it by the combining the panel of markers that we have as well as the routine panel of markers. Nothing hi-fi, nothing fancy, just one additional layer of molecular testing. Now this series basically highlights, as I said, that the WHO CNS5 classification has kind of divided the gliomas into pediatric and adult type. And in children, the low grade and high grade are usually clearly demarcated because the low grade gliomas almost never progress to high grade, and in the adult, the grading is more of a continuum, as we know, and this is the basis for the current classification. However, in the AYA group, there is, as I said, complete transition from the pediatric type to the adult type. So in this particular age group, we can see the whole gamut of gliomas, and they form a significant chunk of tumors in the AYA, about a third of them, and about a third of those are high-grade gliomas. So in the light of WHO 2016 classification, we were already doing IAPM as a first panel of markers, but now we need to supplement it with OLIC2 and H3K-ME3. That will kind of help us to choose what for a molecular testing we should do. And we should attempt in any high-grade glioma in AYA to try to identify the particular type of mutations associated with it so that the adequate management can be taken. Now, the next series of cases will be a set of twins, one in the supratentorial, one in the posterior fossa and the spinal region. So the first set of twins from the supratentorial region, nearly similar ages, both hemispheric, relatively well circumscribed superficial cortical location tumors. And in the first case, you can see that there is a prominent perivascular lymphocytic infiltrate. Yeah, perivascular, I don't think this is working. So, yeah, prominent perivascular lymphocytic infiltrate, cells with markedly pleomorphic nuclei, very bizarre cells, some areas of fascicular architecture, and high-grade features in the form of necrosis and MVP. In case 5, again, very similar looking, but the presence of eosinophilic granular bodies and cells with abundant cytoplasm, and as well as there were areas in which the cells were arranged in very fascicular spindled architecture with again interspersed multinucleate tumor giant cells. So, the routine immunoprofile actually did not throw up very much anything significant. IDH wild type, ATRX retained, OLIC2 positive, focal CD34 positivity, and increased intratumoral reticulin. So, kind of PXA-like differential morphology. And in case 5, also similarly, there was nothing significant except more patchy CD34 positivity. GFAP highlighted the more EGB areas where the EGBs were present, and it was relatively negative in the areas where there was a fascicular architecture. Reticulin was rich in the areas of fascicular architecture. So with the PXA-like morphology, we went ahead with the sequencing for BRAF V600E. And in the case 4, you can see that BRAF V600E was mutant. So in this case, the diagnosis was a PXA, WHO seen as grade 3. However, in case 5, the BRAF was negative, and in keeping with the morphology that there are distinct areas of spindle architecture, increased retic, loss of GFAP, the diagnosis is more in keeping with the gliosarcoma. Now, this series of cases I have kept to highlight the association of BRAF V600E mutation with the AY group. It can be seen across a number of tumors in the WHO classification, and almost all of these entities are more frequent in the AY group, including plenty. We heard yesterday diffuse astrocytomas, circumscribed astrocytomas, low grade, high grade. In the whole gamut of this thing, we can see a BRAF V600E mutation. So we have to remember that the diagnosis is not based on BRAF V600E alone. It is not a mutation-defined WHO entity, but mutation with the specific morphology can help you arrive at a diagnosis. And the significance, of course, being that it is a druggable target. This case also I took to highlight that in many times when we see a PXA or a high-grade PXA-like morphology, there are a number of differentials where it's very difficult to differentiate from routine glioblastomas. And it is in fact recommended that any GBM below the age of 30 with epithelial morphology, PXA morphology, as well as other circumscribed gliomorphology, we should screen for an IDH, screen for BRAF V600E by IHC if available, or sequencing for confirmation. And then that patient might be amenable for therapy. On the second series of cases, third rather, in the posterior fossa. So this is a 20-year-old female and a 19-year-old female, both showing well-defined masses in the fourth ventricle, and very similar morphology of kind of monomorphic round blue cells arranged in perivascular pseudo-rosette pattern. First case showing a little bit of mitosis. In the second, there was no significant mitosis, but some amount of hyalinization. And on immunohistochemical panel, being the location radiology as well as the morphology of ependyma, the tumors were positive for GFAP, negative for OLIC2. EMA was perinuclear dot-like in case 7, but in case 6, there was complete loss of S3K27Me3, while it was retained in case 7. So in case 6, the diagnosis was PFA ependyma, morphologically favoring CNS WHO grade 3. While in case 7, it was a PFB type of ependyma. Now, the significant being that in the, as we know in the posterior fossa, PFA have a definitely a worse prognosis, but they are known to occur in children. However, it is not a high risk only in children, but to all the ages where PFA morphology or PFA molecular phenotype is seen. So any young adult with the PFA would have the same prognosis as an infant, thus highlighting the need to do a routine S3K-MA3 in this kind of tumors, even if you have the age as a young adult. And especially in adolescents, PFA and BFB kind of, again at the crossover ages, they have approximately equal frequency, and they're most likely to benefit from routine diagnostic subgrouping. So this is a simple IHC-based test with loss of ME3, which is now included in the essential criteria for the WHO CNS5 classification, and it can be supplemented, as you heard yesterday, with the FISH for 1QK. Now, the last series of cases, little different ages, little different location, 36 and 15. One was in the lumbar, one was in the C4 to D4 region. However, the most identical twins till date, both showing monomorphic round cells infiltrating with the prominent perivascular arrangement, areas of necrosis, very frequent microvascular proliferation in both of them, and a little bit of diffuse morphology in the second. On the routine histochemical panel, OLIC2 negative, S3KM3 written, being a spinal location, ependyma morphology, we did a fish for Miken, which was amplified, so this was a spinal ependyma Miken amplification. However, in this next case, it was a surprise to us that though the GFAP showed a very nice perivascular accentuation, the OLIC2 was diffusely positive. And we confirmed this further with the SOX10, which was also positive, and there was S3KM3 loss. So this gave us a clue to our next marker, that was in S3K27M. And this was a diffuse midline glioma with very prominent ependyma-like morphology. So this was just to highlight that SOX10 and OLIC2 are good negative markers for ependyma, and they can help you pick out not just the diffuse midline glioma in spinal locations, but also in the posterior fossa, and to differentiate in pilocytic. Now, also we have to remember that in a spinal ependyma, if we do a Miken, unless we have ruled out diffuse midline glioma, the Miken amplification, we should not call it a spinal ependyma Miken amplified, because that can occur in diffuse midline gliomas also. So the take-home message is that the AYA group forms a very heterogeneous population of tumors with a very wide array of differential diagnosis, and we have to think of possibilities and cast a very wide net with taking clues of site, pattern, histology, and IHC for choosing the appropriate molecular testing. And also just a disclaimer that molecular testing is in nascent stages for several entities in this group and is likely to evolve further. I would like to end by thanking Dr. Sridhar, my senior colleague, Dr. Ekta, my junior colleague, Dr. Jayesh, who is a molecular path fellow, our residents who helped in searching these cases for me, and the members of the Neuro-Oncology DMZ. Thank you.
Thank you, Dr. Ayushi. I think that was a very, very lucid description of how, things which, as you put it, twins which look alike are so remarkably different. So excellent talk. Thank you so much. I think we'll keep questions and discussions towards the end. So next I request Dr. Rakesh Jalali to give his talk on the challenges faced by AYA group.
That was a brilliant talk, Ayushi. We enjoyed it very much. So, as has been already told, the AYA population does represent a very significant chunk of brain tumor patients. And unfortunately, as compared to pediatric and adults, the research and the outcomes are a little bit lagging behind, not only in the CNS, but in general. And therefore, for the last few years, there has been an amazing interest in the AYA population worldwide, including CNS. The Central Brain Tumor Registry of the United States, actually, when they published this data a few years ago, that really piqued the interest throughout the world. And this was among the first ones to recognize this entity of 15 to 39 years, and was also the first ever report to provide histologically specific statistics. And you just saw the update as well. And in the last few years, especially the CNS5, there are several tumors in the AYA population. You had a beautiful bouquet of cases just now that you heard, which demonstrate or illustrated the same. People don't realize sometimes this is the third most common AYA cancer, but more disconcertingly, it's also the third cause of cancer death in a very productive life, 15 to 39 years, when the people are at the peak of their lifetime. Several years ago, when this was done in TMH, Rohit Vadgaonkar, who was our senior registrar at that time, he, and along with other colleagues, we put up our cases together, and we tried to look at 5 years data from 2011 to 2015. And actually, among almost about 7,000 odd patients, we demonstrated that about 1,800 odd patients belonged to the TYA, 27% of all the cases with the male and female ratio, as you can see. That time it was kind of a nascent stage for the molecular biology or molecular pathology, but we did compare our data with the Central Brain Tumor Registry of the United States data, which was, of course, about 53,000 patients, but that was, in entire North America, and we were just one hospital. But nevertheless, there were some interesting data sets, as you can see. As you can appreciate, the astrocytomas and glioblastomas seem to be slightly more in our group as compared to the CBTRS, because we were kind of a neuro-oncology database, and the CBTRS combines both the benign and the malignant ones. So it was more like a selection bias rather than that we really had more GBMs. As you can also see in the other group, there was not so much difference in the embryonal tumors and others, And there were also perhaps reflection of, for example, meningiomas, we saw only 4% as compared to 15% in the CBTRS, again reflecting the selection bias of the cases that were captured in these two registries. We looked still at a reasonably good cohort of 1,400 odd patients, looked at the IDH mutation, and interestingly, what was demonstrated was that, you remember this was many years ago, that time the CNS5 was not there. But even then, we were among the first ones in the world to show that there is a distinct differences between the pediatric population, the AY which straddle between the two, and of course the older adults. And now, as you now know, I was very carefully watching Ayushi's, every time she has written pediatric type, adult type, now it has to come into our mind that we have to write adult type, but it has to be a hyphen. One or two places hyphen was not there, Ayushi, I saw that. So it has to have that also. So you have to see that time. And there was some interesting statistical significance as well. You already saw one very good case of PXA. This was again, one of the largest data sets from a single institution that we published a few years ago, particularly the impact of 2016. Now, if we start writing on impact of CNS5, I think we'll get 100 papers out of it. That every single case has been, shown so much difference, but as we know, also can be seen in ganglioblastoma, epithelioid glioblastomas. And as you heard, that there are several targeted therapies along with, and that's the excitement that we have. I do want to talk a little bit about epithelioid glioblastoma because somehow we have not discussed yesterday so much as I was hoping for, because we are somehow increasingly seeing epithelioid GBMs. And this is one case, she's doing still very well. This is one of the few epithelioid glioblastomas. They can have a variant. I think Nilesh was asking yesterday. They can have a very early leptomeningeal metastasis. They typically occur in the cortex. They can bleed. Aditya always tells us that this could be an epithelioid because they typically present with hemorrhage, and Rupesh has operated upon some cases as well. So this lady somehow is doing very well since 2016. She's now 6-7 years down the line. She's on BRAF inhibitors, both dual inhibitors of dafrabenib and MEK inhibitor of trametinib, along with bevacizumab, although we had to re-radiate her after 4 or 5 years. So there is a group of patients in glioblastoma which may do well, and this is typically seen in AYA population. Unfortunately, the diffuse midline glioma, although we have encouraging responses in the H3K27M, but we also know that the AYA diffuse midline gliomas, they do slightly better than the pediatric ones. And this has been demonstrated both in the thalami, they can have the EGFR mutation, they look like similar, kind of a bisimilar on the bithalamic pattern. But interesting thing, which I want to throw the question to Sridhar or others, are there any diffuse midline glioma in the pediatric population which are H3K27M mutant but have a long-term prognosis? I was trying to look at the literature. Dr. Sushma showed us a data set of 650 odd patients, dividing into pediatric, AYA, and the adult. And it seemed there are few cases which have been shown that to have a better survival as we generally think of. Now, we have discussed ad nauseum about the G34, and we see them. The thing is that you didn't realize, and once you have a new entity, then every week or every 2 weeks you say that to diagnose these patients for some reason. That doesn't mean they suddenly crop up. It's just the sensitivity, and your microscope and molecular also somehow gets aligned to it. And then you see this G34 and other things. So we have now quite a few cases, Rupesh will bear with me. And interestingly, they have promoter and GMT methylation. ATRX is lost. That's again very interesting because we used to think ATRX loss doesn't matter IDH, it will be astrocytoma, but that's not true. Even ATRX can be lost in diffuse midline gliomas. So these have to be borne in mind. And more importantly, as I was mentioning briefly yesterday, 2 fascinating papers have come, one in Cell, where they have shown platelet-derived growth factor A, PDGFRA, and we were discussing yesterday, and also the CDK4/6 small molecule kinase inhibitors are being tested in this group of patients. I'm very proud of Roshan Kumar Patil. Of course, Tejpal led, kind of mentored him. This is probably the largest AYA series ever published from a single institution in medulloblastomas, of only about 162 patients data. And this is quite interesting because even in this group of patients, we could demonstrate that there was distinct survival differences between molecular subtypes and histological, with large cell anaplastic being the not so very good. In other words, could be either group 3 or P53 driven sonic hedgehog and wind pathway. Archo Gupta takes the credit for this fascinating piece of work where he divided the sonic hedgehog within them, the differences between the infantile, which do very well, pediatric do the worst, and the adults, they typically present with local recurrences, pediatric with leptomeningeal, and they also are the ones which can have extraneural metastasis. Germ cell tumors is a classic AYA CNS tumor, because you can have both the germinomas as well as non-germinomatous CNS tumors, and sometimes basal ganglia are more common in the Asian population, particularly in Japan. We know that Japan, Korea, and the east part of the Asia would have more incidence of intracranial germ cell tumors. And AIMS, 3 groups in Kolkata, as well as our group, pulled our data together to publish this series a few years ago by Dr. Sarkar's group. And then we also have some Indian data on the intracranial germ cell tumors. Localized germinoma, there is a tendency to reduce the doses of radiation as much as possible. You typically give them 4 cycles of chemotherapy, and whole ventricular radiation is sufficient, while in leptomeningeal metastasis and non-germinomatous, we still have to give CSI. There is a large data set of intracranial germ cell tumor of 40 years, institutional review, but 112 AYA patients, largely driven by germinomas, but you could have non-germinomatous as well. There is a very increasing role of using proton therapy in the germ cell tumors, both the whole ventricular, because you can spare significant amount of normal tissue. The radiation oncology colleagues would recognize that IMPT, the intensity modulated proton therapy with a small spot size of 3 millimeter, is superior to 8 millimeter spot size, is better than the scatter technology of proton beam, and of course is better than IMRT. So this is a very, very good indication for proton therapy. But most importantly, at the end, I would like to highlight the issues faced by CNS brain tumor population. And it is a very sobering thought that while you can get the fancy diagnosis, you can get all the markers, you can do the NGSs and sequencing, and you can cure a lot of them too. But this group of patients does have a very significant symptom burden and survivorship burden when they grow up because of fatigue, growth disturbances, alopecia, impaired fertility. Mind you, there an AYA population, the sexuality, the depression, self-esteem. Highest group of CNS tumor survivors have suicidal ideation, which is again very, very important for us. They are the ones who are least likely to be employed, and they are the ones who are least likely to marry and cohabit. So these are very, very important aspects of survivorship, which you also heard from Dr. Kurkure. Now you can do many things. Of course, you can observe them. You can de-escalate the radiation volumes with the latest technology. This is just proton, but it can be done with the IMRT as well. But there are some interesting, because it's not only that, it is the stroke, the cataracts, obesity, alopecia, ataxia, headache. You can see they are significantly lower with the more modern radiation technologies. We also heard that wind pathway, you can de-escalate. And our own TMH study has also shown, and many other studies in the world are doing the same. We have demonstrated in the past the impact of high precision radiation therapy, the importance of neurocognitive. A good number, almost 50% of the patients belong to AYA, where we showed a correlation with hippocampi. And Abhishek Chatterjee in our group in TMH, we published this data on the SCRT trial looking at in activities of daily living in children and adults. And so it's not only about the survival and cognition, but these are simple things like Lotka score, the activities of daily living, the Barthel, and there you could see demonstrate the improvement in the modern radiation as compared to the older, in order to reduce the survivorship burden, because that is very important. 1.5 to about 15% of the tumors in childhood cancers eventually develop a second cancer, which is again very, very important, both because of radiation, genetic, as well as chemotherapy. And so therefore proton is there good as well. In adolescents and young adults, there is a 176 data set, all belong to AYA, looking at base of skull tumors treated with pencil beam scanning, proton therapy. And again, this is coming up quite well as well. Now, finally, as I mentioned, there is a long-term support. So it's not only the survivorship should include the social aspect, the physical, spiritual, psychosocial, cognitive, and so on and so forth. And there was a very nice survey done where they showed that the two least important points that were not captured were the spiritual aspect and the psychological aspect in this population. And that is something which we have to look at. We also there was a survey done by SEOP, I think by ASMO, where by 28 Asian countries, 78% did not have any access to specialized cancer services, and 73% were not aware of any AYA, but there is some growing interest in many, many countries. In our own setup, we have very ambitious program called ALAP, which will be dedicated to the AYA population, which will be run by a nurse fulcrum, and we are very much hoping that we will start very soon about the psychological aspects, the genetic counseling, fertility, survivorship clinics, and so on and so forth. So summarizingly, a significant proportion of CNS tumors do belong to AYA group, who present with unique challenges in terms of distinct demographic, disease profile, pathological and molecular profile, as you just heard, but very importantly, the outcome and survivorship very distinct from pediatric and older adults. They definitely need special focus in terms of care, research, awareness to customize and personalize comprehensive management plans for their optimal outcomes to maintain quality of life, societal integration as normal individuals. Fortunately, there is a growing interest in the field, and I must recognize in this forum Professor Prakash Chitalkar's tremendous untiring effort, including instituting an award in ISNO every year dedicated for AYA research in CNS tumors. So it's great initiative by him, and growing interest in the field by several groups, but needs reinforcement from clinical groups, CNS patient advocates, AYA group, healthcare planners, and everyone. I'd like to acknowledge all the teams in TMH and Apollo, and for all of you for your hearing. Thank you.
I think first I'd like to invite Dr. Chitalkar for his role as a chairperson.
In several branches of all the cancer entities in AYA age group for the last 6 years since the foundation is formed. But Dr. Jalali has taken a quantum leap, I should say, in the CNS tumors of AYA, and I think the other entities actually lag behind, and we really seriously need to think how we can catch up. So thank you very much, and big round of applause.
So I think next talk is by Dr. Ashis Pathak about stereotactic radiosurgery in special situations. So it's a pleasure to introduce him. Dr. Pathak has been one of the earliest people from the neurosurgery side to get into radiosurgery with a lot of experience he spent a number of years at Sheffield also doing and training in this field. So Dr. Pathak.
Thank you very much. First of all, I really appreciate the permission that you gave. I joined late, and Dr. Aditya, Dr. Indu, and Dr. Rakesh, of course. I come here in this conference as a student. Neurosurgeons, molecules, genes, neurosurgeons, they are very difficult. So I come and learn every word here. And that's where the patients now know better than me, actually. Google uncle is there. So anyway, this is a very interesting topic. I give credit to this man for whom we talk about radiosurgery today, Lars Lexell, way back in 1957. He conceptualized the concept of radiosurgery. And this is his first prototype at Stockholm. And I'm fortunate to see that things are changing fast, not only in gamma knife, but also in SRS in the various forms. And this is the place where the first center for radiosurgery outside Stockholm in Sheffield was established. And this is to cater to all the patients in the Western Europe and things like that. So this is way back in the year 1993, where I was trained as a research registrar there. And David Foster, my mentor, was really a great man, and I learned a lot from there. And we are fortunate to have the gamma knife in PGI. So I can claim that I'm one of the first neurosurgeons in the country to be trained formally in this field. we are all victims of vomit. Now, what is vomit? Victim of medical investigative technology. And it is a very common thing to see. A patient walking to my clinic and say, brain mein mera tumor hai. What is the problem? No, tumor hai. How did you know the tumor hai? He had an MRI for some other valid reason. And then they find a tumor and he forgets about the symptom then and he is now running after that particular tumor. Something needs to be done. Now, question is, he has got a small intracanalicular acoustic neuronoma, which is there sitting, it's incidental finding. Now you have to explain to him that this tumor will grow, it will grow slowly, it's rare to grow, it will reach a size, you have no symptoms, what to do, but then that tumor is sticking to his head. So then you have to start really trying to teach him what the things which can happen. So this is, what is the rate of growth? First, let's learn ourselves. The rate of growth of acoustic neuronoma has been found to be 1.5 millimeters per year. And then there are studies which say 5 to 10 years, nothing grows in some of the tumors. So they are again a varied basket of tumors which have a different sort of way, the dynamics is different sometimes. And there's no environmental or dietary factors which influence the growth. So can we predict the growth in certain tumors? Yes, if there's cystic or hemolytic features, you better keep a watch. The patients are on hormones, better keep a watch, and they can go at the rate of 4 millimeters per year. And I'm not talking of the NF. NF and acoustic and lesions are different categories, so they are different. So you have to deal them in a different way. And then he will ask you, can it become cancerous? The answer is no. In most of the situations, it won't become cancerous. The other thing is that what symptoms can I have if it goes? And this I'm going to the practical things which I face every day. Well, you can sometimes have a little bit of facial pain and worsening hearing, but before that, we'll try to catch your symptoms and we'll try to treat you if it really happens. So this is the way you try to explain to the patient. And it is very rare for them to grow fast and have symptoms also. So now that we know, we can monitor you. So what is the best treatment? He will ask you, well, SRS has an edge over surgery because it's non-invasive, but then it tries to balance out the effect on the surrounding structures. But even then, you have to also tell him that the reverse of FRS is not 100%. So tumor control is 90% average. Improved risk of complications is there in comparison to surgery, but in the long run, there will be a functional hearing loss in 50% of the cases, and that gets worse with time. So those things now you have to balance out. I want a gradual functional hearing loss in the long term, 50% or less than that, or I would better sort of carry on like this, and who knows, in 10 years, nothing will happen to me. And we know that the complications of SRS has declined over the years. There is only one case which has malignant transformation. The control in acoustic is 92, 91, 91, 5, 10, and 15 years. And of course, the overall control rate is 98%. And there's 55 of the patients who can have some functional hearing loss. But with time, it comes down to even 34%. So these are the statistics that we have. So ultimately, what to do? You can just give him that following advice. We can monitor you with image surveillance, electrophysiological surveillance. We can do an SRS if it is needed. And the surgery in good hands can also give a very good result. So don't deny that. And then the final call has to be taken by him. So this is a situation where even the doctor community is not aware of the various options. And they just trigger the patient with the fact that you've got a tumor, go running to a neurosurgeon, get it removed. So we have to be cautious in this situation. These are the situations where it takes a lot of time to explain to the patient and bring his emotions, his thoughts, his psyche in a better control, and probably ask him that go and think, don't jump the gun like this. Similar situation, very common, pituitary tumors. No symptom, no deficit, no endocrinopathy, and he comes running to you. I've got a tumor in my head, do something. I've been told by my doctor that I need immediate surgery or something like that. Again, going by the statistics, these incidental tumors, as they call it, they can be as high as 10%, 20% in certain populations, and the prevalence can be 1 in 1,000 people. I don't know whether I have got one. I've never checked my brain. And the natural history is not fully understood. And the smaller ones, they grow very slowly. And the acroincidental tumors, which are more than 10 millimeters, require more attention because they can have a little bit of growth, abnormality, visual problems. But now that we have known the devil, we can keep a monitor on that. And there's a meta-analysis done on that, which shows that the macroadenomas grow at the rate of 12.5% per year, 5 to 7% for solid tumors, 3.3% for microadenomas, and in cystic lesions, it's negligible, almost 0.5%. So you have to very carefully choose these patients and try to explain what are the possibilities. Most of them are diagnosed because of headaches or some other vague cause. Headache in pituitary tumor is known, and sometimes doing the surgery can cure the headache. I don't know why, but yes, small tumors with headaches can be there, but the headache can be for different cause. So you have to be very cautious, because if you can't cure the headache after the surgery, then you are in trouble. The patient might be having a migraine, and that's never cured with surgery. So the options here again are radiological surveillance, ophthalmological surveillance, and of course, endocrinological surveillance. So there is a laid down sort of rough guideline which has been suggested. It's a microadenoma. You do MRI and biochemical testing in 6 months, and then after that, if everything is stable, repeat it every 1 year and do the visual field testing every 6 months. That's helpful also. For micro, of course, once you have checked it after 12 months, then you can just go for 12 months. And there is no need to even check for hypopituitarism in these cases. So that I'm talking of non-functional pituitary adenomas. Don't confuse with the functional ones. They're different category. So I just want to clarify if I've not clarified earlier. Another very common thing, very, very common, I tell you. Somebody is having seizures for 15 years and suddenly somebody decides to do an MRI and you find this. And we find the seizure focus has nothing to do with this. Or somebody is having a headache or some vague symptom like vertigo or something like that, and this is found. And this is there in the adults. So again, here in this case, observation, surgical resection, radiation, that is decided. Now, I've got two figures on the right. The one is a small one, which probably doesn't need to be done anything, just observe them. The one on the right, of course, it is asymptomatic. It's an incidental finding, such a big tumor. They can be incidental finding. But in this case, probably that needs to be excised. Because sooner or later, this will be symptomatic, and this sort of big tumor should not be left behind. What are the rationale of treatment? SRS has got a rationale because it can treat the tumor very well, but meningiomas, remember, has got a wider base. So what you see, there is an extension into the dura. So in this case, of course, the size of the lesion, the brain invasion, the dural tail, all these things will be considered. Unless the patient has no contraindication for surgery, surgery should be the first choice, because then you try to remove as much as possible. And in the meningioma talk, I'll tell you how meningioma is a totally different category of tumors, though they are benign. So the patients who are not fit for surgery and yet you have to do something, in that case you should do, but small tumors you can just observe, and sometimes the patient outlives the tumor, they don't grow. Coming to a very controversial topic, brain metastasis. Now, it has been suggested that stereotactic radiosurgery is ideal for brain metastasis for cognitive preservation. And the local control sometimes is claimed to be about 90% for 1 year. We know there are treatment for brain metastasis, which can be chemotherapy, surgery, stereotactic radiosurgery, whole brain radiation therapy. Combining all these also can be a possibility. Now, I put whole brain radiotherapy now below stereotactic radiosurgery because this has become talk of the day. And coming to the comparison of the both, if there is a good systemic disease control and you have the complications of whole brain radiotherapy, that's where the stereotactic radiosurgery gets an edge. And ideally, if you got 1 or 2 or 3 lesions, that's great. But people have even gone to give stereotactic radiosurgery in 17, 23, 40 metastasis. So this is also being done. And it's claimed that cognitively it's supposed to be better. And the outcome, of course, doesn't really change. But one thing you must remember, that the response assessment of stereotactic radiosurgery is complicated by the radiation changes which happen also. So they're not absolutely, as pristine as it is thought. The only apprehension here is that though stereotactic radiosurgery is emerging as an alternative in treating these tumors to preserve the cognitive function, but there can be omissions. So what you see today is a normal looking area can become a metastatic area soon. So you have skipped those areas And so you can have this sort of cherry picking going on in the brain. You can have again a second session in certain situations if something crops up. But in the long run, the issue will persist. The other thing, of course, you remember, stereotactic radiosurgery has got a defined size to treat if it is less than 3 centimeters, and in the deep-seated location, that's fine. But more than 3 centimeters, either you go for surgery, and if they have got a dural or pile involvement, then of course you'll have failures. In breast cancers, which are the highest risk of leptomeningeal progression, the patient can have the problems. So the dilemma is that the first line of treatment is supposed not to be radiosurgery, yes, but at the same time you can have salvage treatment for patients of SRS where it has failed for whole brain radiotherapy. I'll quickly go through glioma, another very hot area and very debatable area for radiosurgery. Low-grade gliomas are usually treated combination of surgery, observation, or radiation. But if the tumor is located, it is safe to remove. That's the best treatment still I would advocate, because that gives a long-term better outcome and cure and avoidance of recurrence. But if you can remove it completely. So goal of the low-grade glioma is to prolong the survival and reduce the morbidity. So surgically, if you remove, that's fine. But now SRS has been tried in multimodal treatment in progressive, recurrent, or unresectable polycystic or WHO grade 2 fibrillar astrocytomas, and they promise to be safe. But then again, you have to remember the size of the LGG, the brainstem location of the LGG, and refuse LGG. They are not coming in this gambit, so it's a debatable issue whether we should go for it. The problem is when people are now trying to give SRS for GBM, is it justified? Because it's a highly infiltrative tumor. There's argument about whether we really can cover the whole area, and it has got the infiltrative margins also. So they would fail when the SRS has not really done good coverage, and after SRS, the people found that on the imaging, the MR spectroscopy, the MR perfusion shows that the adequate margin has not been covered. And normally we cover 2 centimeters, but then sometimes it can be beyond that also. So the two phenomenon where we fail, one is inadequate dose, and secondly, the geographical failure. You have not gone to the boundary in GBM. And yet, if you're giving SRS, that's a problem. So they combined SRS with fractional, conventional radiotherapy with fractionated SRS. So they gave 50 days conventional radiation therapy with 4 fractionated stereotactic radiosurgery once a week, and there was no survival benefit. So the problem is, this is where you see the way this tumor infiltrates, and you see the MR perfusion, where the tumor is going. And this is what happens. There's a collective invasion, visual cooption, perineural satellitosis, diffuse infiltration. So all these are not to be covered. And yet you see a series of patients being tried on SRS. But the problem is that they are weak in terms of sample size, the selection bias, the absence of high-level data. So SRS alone or as a boost following external beam radiation therapy is not considered standard therapy in patients and newly diagnosed GBM. So they now talk of leading edge radiosurgery, border zone radiosurgery. They said we'll give the conventional radiotherapy to center, and the edge we'll try to map out on the imaging and then give SRS to that. And they have tried all this and tried to show that the survival is better. But here again, there's a selection bias, and it's not a really properly, double-blind control study. So the problem is that glioblastoma is highly infiltrative. Hence, upfront focused treatment seems inappropriate. Surgical decompression is a better choice, guided by neuronavigation, intraoperative MRI, use of inflorescence. And of course, decompression offers an immediate cytoreduction, and the edema will be better, and thus rapid relief of symptoms. So people have tried to give SRS in some high-grade gliomas, but the age should be less than 55. They should be grade 3, not grade 4. And the KPS should be more than 70. And for recurrent IgGs like grade 3 astrocytomas, in younger age, higher KPS, small size tumor, yes, you can try SRS, but we are not sure how it is. So the standard treatment for GBM still should be maximal safe resection, fractionated radiotherapy to 60 grade in 30 fractions, and then of course chemotherapy should be added. So in conclusion, SRS is not appropriate in patients with focal recurrent in most patients, except in focal recurrent GBMs. And the future has need to be lot to be done to understand the situation. So, in this few minutes, I try to cover up areas which are very controversial and where you really don't know where to go. The role of radiosurgery is expanding day by day. There's no doubt about it. Now we are going to functional radiosurgery and things like that. The main problem is in many situations, the indication does not seem to conform with the evidence-based medicine. There is a dearth of scientific trial to endorse the use of SRS in many situations. Hence, the need for a judicious use of this modality is desirable. And even though it may be the treatment modality in many situations, but the indications have to be judged by the biology of the pathology. So that's my experience sitting in the outpatient clinic and facing the patients. And they come with all sorts of literature where you have to really answer them very adequately. Thank you very much.
Thank you, Dr. Pathak, for a nice overview of radiosurgery. So I think now the situation has turned that every day we get patients asking for radiosurgery, and you have to tell them surgery is better for you. So
surgery is better, or even observation is better in many of these benign conditions. I don't indulge straight away, So they have to educate it. The problem is with the medical fraternity. Most of the GPs and the doctors in the periphery, they would say tumor, daudo, abhi nikalo isko. This might be the cause for your vertigo, headache, or whatever it is. It's not the fact. He might be having spondylitis, for which he's having vertigo. And yet, the patient runs for it. So you have to really put his psyche down. So don't worry, calm him down, and he should not get worried about it. He said, we are there, we'll monitor you. And you might be fine for the rest of life. You just had an incidental tumor which you never knew. This is a first day picture of it. We don't know when it was born.
The other thing about incidentaloma treatment with radiosurgery is that I think radiology is very, very important. It's very easy to burn your fingers by treating something which you think looks like a meningioma. So I've seen a bunch of these cases treated with radiosurgery somewhere, and you take a look at the T2 and you see such a hypo lesion. Meningioma is never hypo on T2, barring very few rare ones. So one such case turned out, which I reoperated, turned out to be a fungal lesion in the anterior skull base. Another occasion, I was not happy assuming a lesion to be pituitary adenoma. So this was some 15 years ago. We did transsphenoidal surgery. It came out to be a pituitary tuberculoma. So in our country, you have funny things which you can see all the time. So that should be at the back of your mind whenever you're trying to treat.
You're absolutely right. Just a month ago, I was told that this patient was pituitary apoplexy. So I was wondering, should I operate or not operate? He had visual problems. And then this patient, the symptom was, रात को जब सोता था घबराहट होती थी मेरे को, no symptom. And somebody got a CT done for the घबराहट, and there was a lesion, and he had an MRI, and they said this is pituitary apoplexy. And I burnt my fingers in pituitary apoplexy because when I went in after a month, nothing was there, everything dissolved. So since I'd committed to him and it was a private practice, I said, okay, I'll go in. Lo and behold, the pus came out from that wound. It was not an apoplexy. And I went back to the radiologist. They said, no, I can't say it's a pus. And that's where it is. And now he's on ATT.
So just 3 days ago, a 17-year-old girl referred for radiosurgery for what looked like a pituitary macroadenoma. So, the pituitary adenomas have a differential enhancement with respect to the rest of the gland. So I was wondering, why don't I see the rest of the gland? So I referred to a very, very experienced neuroradiologist, and he confirmed this was just pituitary hyperplasia in a 17-year-old young woman, which is physiological hyperplasia of the pituitary.
Very true, very
true.
So,
let's not get caught giving radiosurgery to such lesions. So with that, I think we'll probably have 1 or 2 questions about the AYA excellent talks that we heard. So thank you, Dr. Pathak.
Thank you.
Can I make a comment about, continuing to what you said, in the province of adult solid tumors, now we have ALK positive lung cancer in non-smokers, which is a subset of adenocarcinoma. They do excellently for years and years in spite of having CNS metastasis. And again, because they got excellent targeted tyrosine kinase inhibitor therapy. And if the metastasis happens to be the eloquent area, if it is causing symptoms, there is reason to do SRS. Otherwise, medical treatment with tyrosine kinase inhibitor, alectinib, brigatinib, and crizotinib. Actually, crizotinib doesn't cross the blood-brain barrier, but the other TKIs, they can do well for 5 years and plus. So now ALK positive lung cancer adenocarcinoma has become the new chronic myeloid leukemia, so-called. Just like we say imatinib in chronic myeloid leukemia. So these are medical advances are coming up, and so we have to be, Dr. Pathak's central theme is that you have to be extremely cautious about the demand from the clientele suffering from the syndrome of vomit. I think it's extremely justified. Thank you.
Pleasure.
Yeah, I think Dr. Chitalkar is right. SRS with immunotherapy has a much better survival, overall survival. If we do SRS, brain mets and immunotherapy for lung cancers, melanoma, so it has a very good survival, overall survival rate. And I just want to ask Dr. Pathak regarding post-op SRS or pre-op SRS, which...
Well, it's the tumor size, first of all. You have to remember, SRS has got its limitation of the size. You give SRS to big lesion, now you can fractionate it, now you can sort of do different modalities to treat large lesion, but in the brain, the edema after radiation, even after SRS is there, and then the patient will have a lot of problems. So if it is a big one, I'll try to debulk it, reduce it. But most of the pictures that we see in the literature are small dot-like, metastases, and they try to give radiation. So that's a different story altogether. But large lesions, please debulk it first or remove it first and give it SRS to the bed that people have tried. So in metastasis, yes, for few metastasis, which are very well localized, or in eloquent area, deep-seated metastasis, SRS is the only option perhaps. But for diffuse 40, 50, 26, I think I have to wait to learn more. And Dr. Jalali wants to add more.
No, this is a very good question you asked, because now 2 randomized trials, as we know, cavity radiosurgery in SRS has come very well, and we have also started doing for the last few years.
Right.
But the trouble, as you rightly said, is that target volume becomes so large.
Yes.
And you also showed very nicely the breast cancer, especially HER2 positive or TNBCs, they have especially short DFI.
Yes.
They have a very high risk of leptomeningeal. So, you can actually miss the tumor. So there is an increasing thought, and there is a randomized trial going on in the NRG where they are doing pre-op SRS. So they do SRS followed by surgery, and that seems to be very interesting because you have to give SRS and both combine anyway. So why not give SRS first, because then you don't have the problem. And I have seen in Miami what they were doing is they were doing the SRS on Friday, admit the patient on Sunday. After Saturday and Monday, they used to operate within 3 days. But logistically, it is very hard. It's not possible.
I am not very sure. Let's see the results.
No, we will see the results, but it is an interesting thought.
It's published, yeah. It's getting published that less of leptomeningeal spread and more better delineation is there when we are doing pre-op.
And finally, I want to also, because now we are talking brain mets, we should not forget hippocampal avoiding whole brain radiotherapy.
Yes.
Which is fascinating because you preserve the cognition, and yet, especially in our country,
SRS has got edge on that.
people don't realize that if you do SRS and brain mets, every single protocol has 3 monthly MRI.
Yes.
Tell me how many patients can afford 3 monthly MRI?
Not possible.
You can't just do SRS and leave them alone.
So I just want to ask about proton therapy, trigeminal neuralgia,
No,
SRS.
no. SRS actually proton is not very good because there is a lateral penumbra.
Yeah.
So in small spherical 1.5, 2 centimeter classic radiosurgery, either with LINAC or gamma or CyberNAC is far superior. But if you have to do cavity radiosurgery, we have done a few, or hippocampal sparing, then proton has an edge.
So I think we'll call it a day. Anything from the audience? We had 2 excellent AYA talks, so maybe one question or comment from the audience.
The conclusion of all the 3 lectures, they were excellent, Pathak, because the postgraduate and young researchers are sitting there, and it was very beautifully defined the line where the SRS is needed, and especially the GPM, where are the limitations for the youngsters. That's very important. And for Dr. Rakesh, I had a question because we were talking of the BRAF mutations and all that, all these young population and pediatric. Although in leukemias and all that, we were using the targeted therapies very widely. And I think we don't have still the big data. And what is the scope of these targeted therapies? We had some limited data for the future. And for Ayushi also I had, because in the flow of the question, talk was excellent. But still, I am talking of my experience. We are still struggling with the good pathologists are there in our country, but exceptions are the 40 to 50% because of lack of the facilities. Can we have our own kitty of the small kitty of these markers for our country or our own, like we have the guidelines? Breast, we are talking of the breast cancer, and people are coming forward. We go for the genetic counseling and all that. And this is the limitations of the pathology, neuro-oncology kitty with most of the centers.
So I quickly answer. So there is quite a bit of interest in targeted therapies, especially in pediatric low-grade gliomas. We had several discussions yesterday. One very nice study is called ROAR study that was in adults though, had included, I think 24 or 25% of the patients were in the AYA. And it's published in the Lancet Oncology, looking at both the dual inhibitors of BRAF inhibitor and MEK inhibitor. And we also have in the Do Not Miss It session landmark paper, a session later in the day, there is Dr. Rohatgi is going to talk something about the targeted therapy. So I think it's exciting in many fields. As far as the markers are concerned, as you know, 2016, we wrote the Indian guidelines and several centers in the country are doing. The only thing is we have to channelize it well. So I think, Ayushi, if there's anything to add, but we are working on it.
Just like sir said, actually after the 2016 classification came out, ISNO published guidelines for diagnosis with limited panel of markers, more important and suitable for our resource constrained settings, that what is essential, what should be done, and what can be left for a specialized referral center if required. So that with the routine panel of markers, that is why I picked up the routine cases from the diagnosis that we see, that with the routine panel of markers, you can get the diagnosis in the majority of cases. And if you're not able to arrive, even Dr. Sridhar said yesterday, once you have a, say, IDH wild type, histone wild type, maybe that is the time where specialized neuropathology opinion should be sought.
Thank you. Thank you all speakers and participants. Now we'll conclude the session. Hand over to the organizers.